This is a brief overview of syndrome of inappropriate antidiuretic hormone, otherwise known as SIADH. Looking at the causes, we start with the brain. Look at brain tumor, injury, abscess, meningitis, subarachnoid hemorrhage. Looking at the lungs, oat cell carcinoma, small cell lung cancer. Look for infections, pneumonia, lung abscess. Other areas would be pancreatic cancer, lymphoid cancer, hypothyroidism, and the medications we'll talk about later in the presentation. One way to remember is that SIADH is too many letters holding too much water. That's why there's an increase in ADH levels. There's an increase in water reabsorption in the renal tubules. Increase intravascular fluid. Think of your blood, the blood volume. A dilutional hyponatremia, and decreased serum osmolality. Another way I remember is placing an up arrow in place of the I in SIADH, like this. This helps to remember that there is too much ADH in SIADH. Now you know what a diuretic does, as it pulls the fluid out through the urine. So an antidiuretic stops the urine. In SIADH, there is too much antidiuretic hormone, so too little urine is made. And this leads to fluid retention, which in turn dilutes the sodium. SIADH is ADH-induced water retention. SIADH is ADH-induced water retention. SIADH is ADH-induced water retention. Now the patient with SIADH experiences low urine output and increased body weight. The clinical signs. The early symptoms of SIADH are related to water retention. GI disturbances like loss of appetite, nausea, and vomiting may occur first. Now this makes sense when you think that water retention, hyponatremia, and fluid shifts affect the central nervous system function. As the serum sodium level falls, usually below 120, the symptoms become more severe. So now we're going to have more severe vomiting, abdominal cramps, muscle twitching, and seizures. When hyponatremia is severe, the sodium is less than 120, or acute in onset, and symptoms of cerebral edema become more prominent, and you're going to see lethargy, confusion, headaches, seizure, and coma. You will need to monitor vital sign changes, and that's going to include looking at their heart rate, because tachycardia could be caused by increased fluid volume. Hypothermia could be caused by central nervous system disturbance. Now this is due to natriuresis, which is retained water and peed out sodium in the urine. Now I know that's not very technical, but it's an easier way to remember it. Retained water and you pee out the sodium. The water retention and sodium loss both cause hyponatremia, and this is a key feature in SIADH. Now if we look at the diagnostic tests, the serum laboratory values, 1 and 2, which is sodium and serum osmolality, both of those are low. And the other 3 are high, the urine osmolality, the urine specific gravity, and the urine sodium. Now other tests that might be done would be you would probably see a decreased BUN and a decreased creatinine clearance, decreased hemoglobin and hematocrit. They will probably do a CT scan to rule out brain disorders and a chest x-ray to rule out problems that could cause SIADH. Nursing management is quite a few things that you have to do. Assessing the heart and lungs, their vital signs and eyes and nose and weights, specific gravity, look at their serum sodium, and their urine osmolality. You want the serum sodium to be 135 to 145. The osmolality urine test measures the concentration of particles in the urine. The normal 24-hour urine osmolality is on an average 5 to 800 milliosmoles per kilogram of water. After the patient has gone through 12 to 14 hours of fluid intake restriction, the urine osmolality should exceed 850 milliosmoles of kilogram of water. Specific gravity should be less than 1.025, but be careful that it does not go into DI, diabetes insipidus. One of the meds to treat SIADH, demeclocycline, can cause diabetes insipidus. So you want to be on the lookout for a specific gravity that begins to drop, and a specific gravity at 1.001 to 1.005 could be going into diabetes insipidus. Now you want to check that the patient is not taking medication causing SIADH. In other words, stop the drugs that may cause SIADH, like carbamazepine, chloropropamide, opioids, thiazides, SSRIs, and tricyclics. The fluid restriction can have this patient feel so dry like the Sahara Desert. A fluid restriction of 500 to 1,000 mL in 24 hours will help increase the serum sodium, reduce the weight, and increase osmolality. Anytime you do I's and O's, you should include weights. Intravenous saline. Now this is very symptomatic patients. They can have severe confusion, convulsions, or coma, and hypertonic saline should be given. May use 3% sodium chloride in conjunction with furosemide, and furosemide may be given to decrease reabsorption of water, but caution on correcting the water imbalances too quickly. Furosemide may cause further loss of sodium, and because furosemide increases potassium, calcium, and magnesium losses, supplements may be needed. Dimeclocycline can be used in chronic situations when fluid restrictions are difficult to maintain. Dimeclocycline blocks the effect of ADH on the renal tubules, which results in a more dilute urine. Vasopressin receptor antagonists like tolvaptan and conivaptan are used to treat euvolemia hyponatremia in hospitalized patients. These medications must be watched closely to prevent rapid correction of serum sodium. The use of ice chips or sugarless chewing gum helps to decrease thirst. The patient should be weighed daily to monitor changes in the fluid balance. The patient will need to be taught to supplement the diet with sodium and potassium, especially if loop diuretics are also prescribed. Restoration of electrolytes must be gradual. If the patient is taking diuretics, the patient should also take sodium and potassium, and these should be taken at mealtime. PO electrolytes can be well diluted to prevent gastrointestinal GI irritation or damage, and care must be taken when correcting hyponatremia, as it could result in a non-cardiogenic pulmonary edema. A rapid rise in the sodium level may cause cerebral edema, which can progress to cerebral herniation. Central pontine myelinolysis is nerve damage caused by the destruction of the myelin sheath covering the nerve cells in the pons, which is located in the brainstem.